between 10 and 50% of the medicine sold in developing countries could be, in fact, fake. In 2010, the counterfeit medicine industry is worth $75 billion.
They have no knowledge of pharmaceuticals. They're just trying to put something together that looks like the original product. But it's obviously quite shocking that people can make products in a backyard facility that could kill people.
I think that these are people who are basically looking to make money. To some of these people, medicine is just a commodity.
It's undoubtedly a disease of greed because the motivation behind it is profit, and there is no concern for the harm that it causes.
You know, it's a clever industry. You know, there's a lot of money there, and so I think, you know, as much as we do in terms of trying to identify, you know, trying to kind of discriminate, look at the discrimination between this hologram and the fake hologram and the true hologram, I think the counterfeiters will almost always be a step ahead of us.
You can find any medicine, any drug, which is having the margin. They are making fake medicines for their profit. If there is a profit, they will make it.
The Burmese border town of Tachilek, infamous as a haven of opium production and smuggling since the 1920s, is at the center of the Golden Triangle. Peddlers at the border markets sell a dizzying array of fake products from China: watches, alcohol, handbags, shoes, and a potentially lethal product, counterfeit medicine. Unsuspecting tourists pick up cheap goods, unaware of any danger posed by consuming shoddy imitations of medicines that can be deadly.
Where's that from? Yeah, where's this from?
This is.
Yeah.
Yeah, no sense. Okay, CLS, and this one too, this one, okay, 500 baht, okay?
Yeah, where you get?
This here.
Yeah.
Viagra.
Where come from?
Strong one.
Where come from?
USA, no.
No?
There's estimates out there that I've read from authorities that say that even in the West, in developed countries, that 1% of the medicines there is potentially counterfeit. Of course, that goes higher in the developing countries, as I said, up to 50% or some estimates of the amount of fake medicines in the developing world.
Sukhumvit Road, the tourist center of Bangkok, boasts a dense layout of markets openly selling anything and everything, including counterfeit medicines, with no attempts to conceal or hide illicit products. Many products contain up to 5 times the recommended amount of active ingredients, a potentially lethal cocktail.
This one is 800 milligrams per pill. 800 milligrams of the active ingredient.
This blatant, in-your-face business is only possible through protection by the local mafia.
I saw first fake medicine in 1982. At that time, there were some generic people, those who were making generic medicines, and their product was not in demand in the market, and they are not getting very good profits. They started it by counterfeiting the big products available in the market of the big MNC companies. They started with that. And at that time, there was some products only, some. You can count it at that time.
Nowadays, we are facing a new trend of increased, antibiotics. Like general use antibiotics, amoxicillin, ampicillin, clarithromycin. These are the lead in terms of poor quality medicines in the region.
Counterfeit medicines commonly available in the market are antibiotics, painkillers, and yes, life-saving drugs.
La sophistication des contrefacteurs, en tout cas des criminels qui sont impliqués dans les trafics, est à la hauteur de la sophistication de leurs produits. Et on retrouve maintenant des contrefaçons de médicaments qui sont complètement à l'identique en termes d'identification, de packaging. Donc on voit que les systèmes d'impression qui sont utilisés par les contrefacteurs sont excellentes, voire parfois meilleures que le produit d'origine, que la peinture utilisée, les couleurs sont absolument de très très bonne qualité et qu'il est parfois difficile de reconnaître le bon du mauvais sans avoir fait d'analyse chimique.
To distinguish between genuine and counterfeit medicines, analysts employ a number of technologies to determine authenticity. In Singapore, the Health Sciences Authority labs tested fake versions of Lipitor, a top-grossing cholesterol-lowering medication which flooded the global market in recent years.
A couple of days ago, an unknown sample of Lipitor was submitted to the laboratory. Today, we are going to run a series of tests on this unknown sample and then compare it to the authentic Lipitor that we have in the laboratory.
I'm looking at the packaging analysis of the samples. So on the left is the authentic sample and on the right is the unknown. I see differences in the printing quality between the two samples. The authentic sample is of a better printing quality than the unknown sample.
To the naked eye, counterfeit medicine can look identical to authentic medicine, so more sophisticated tests must sometimes be performed. One important test to determine the chemical composition and the active ingredient present in the pills is Raman spectroscopy. This method analyzes the different components of the unknown sample and compares them to the active ingredient in the authentic sample of the drug.
When the unknown sample is compared to the authentic sample, we can see that the chemical profile looks different. The active ingredient is detected in the authentic sample, but is not detected in the unknown sample.
We found that based on counterfeit standards, this is actually a very poor counterfeit sample. The sample, the unknown sample, compared to the authentic is very, very different. And the worst thing is that when we checked for the quantitation by our pharmaceutical lab, when they quantitate the amount of active pharmaceutical ingredient in it, it was found to have none. That means there was no active ingredient that was present in the unknown sample of Lipitor that was submitted to us.
In developing countries, such as in the Mekong region of Southeast Asia, the threat comes from unlicensed retail outlets in remote areas, especially along international borders. Many of these mom-and-pop stores sell everyday household items alongside medicines, usually without a license.
They certainly know that the product is coming from outside the normal distribution channels. Normally when they order from the pharmaceutical company, it's delivered by the pharmaceutical company's distributor. But these counterfeit products are delivered by people on motorbikes, obviously outside the normal distribution channels, so that they know that they're either getting grey market or counterfeit stuff. I think there are some cases where they think they're selling grey market, but it's actually counterfeit. They think it's just maybe intended for another market, and they're getting it cheaper because they're avoiding taxes. But I think that there's definitely some cases where they're aware that they're selling counterfeit and go ahead and sell it.
Imported and locally produced medicines circulate through hundreds of wholesale outlets, eventually making their way to pharmacies and health facilities in the remote areas of the countryside. A vast majority of drugs for the private sector first come through the Olympic market, and the Cambodian Ministry of Health closely monitors the flow of these products from importation to retail distribution.
បញ្ហាថ្នាំខ្លែងៗនេះវាទាមទារនៅការវិធានការកត្តាច្រើនណាស់ទីមួយអំពីប្រព័ន្ធចែកចាយឱសថមានន័យថាបើសិនជាប្រព័ន្ធចែកចាយឱសថនៅ មេកានីសដែលចែកចាយឱសថនឹងត្រឹមត្រូវមានការទទួលខុសត្រូវ នោះយើងអាចកាត់បន្ថយបាននៅឱកាសដែលប្រជាពលរដ្ឋជួបប្រទះឬក៏ទទួលបានឱសថខ្លាំងៗទី2វិធានការតាមផ្លូវច្បាប់វិធានការតាមផ្លូវច្បាប់មិនមានន័យថាអាជ្ញាធរសុខាភិបាលមន្ទីរសុខាភិបាលក្រសួងដូចជាអ្នកងារត្រួតពិនិត្យឱសថហ្នឹងមានឱកាសមានលទ្ធភាពគ្រប់គ្រាន់មានមធ្យោបាយគ្រប់គ្រាន់នឹងចុះទៅតាមដានត្រួតពិនិត្យកន្លែងដែលលក់ថ្នាំអត់ច្បាប់ទី3ការបញ្ហាធំមួយទៀតគឺចំនួនកន្លែងលក់ថ្នាំអត់ច្បាប់នៅក្នុងប្រទេសកម្ពុជាហ្នឹងវាហាក់ដូចជានៅរក្សាចំនួននឹងហាក់ប្រហែលអត់ច្បាប់ជាង 1000 កន្លែងមិនមែនជារឿងធម្មតាទេដូច្នេះវាទាមទារនៅមធ្យោបាយការអនុវត្តច្បាប់វិធានការអាជ្ញានឹងផងទី2វាទាមទារនឹងការភ្ញាក់រលឹករបស់ professional អ្នកវិជ្ជាជីវៈនឹងផងហើយទី3ធំបំផុតគឺការអប់រំប្រជាពលរដ្ឋសំខាន់ណាស់គឺការអប់រំប្រជាពលរដ្ឋនឹងជួនកាលយើងធ្វើវិធានការតែមួយអត់បានទេត្រូវគុំវិធានការទាំង3ហ្នឹងច្បាប់ការអនុវត្តច្បាប់ដាក់ទោសទី2គឺវប្បធម៌ការប្រកាន់យកអរិយាប័ត្ររបស់ professional ណាទី3គឺឆន្ទៈរបស់អាជ្ញាធរសមត្ថកិច្ចហើយនឹងទី4ការទទួលខុសត្រូវរបស់ professional របស់អ្នកវិជ្ជាជីវៈទាំងអស់ដូចជា Pharmacide អញ្ចឹង Pharmacide អញ្ចឹងត្រូវតែមានអ្នកលក់នឹងត្រូវមានតែការទទួលខុសត្រូវជាពិសេសឱសថការីហើយនៅអ្នកលក់ឱសថអញ្ចឹងត្រូវតែមានមនសិការត្រូវឲ្យប្រកាសក្នុងខ្លួនថាមុខរបររបស់យើងមិនមែនមុខរបរដែលគេហៅថារកលុយរកកាក់ខាតចំណេញដាច់ខាតទេជាមុខរបរដែលយើងរួមចំណែកជាមួយនឹងការផ្ដល់សុខភាពជូនប្រជាពលរដ្ឋនេះឯងជាសិទ្ធិជា human right ជាសិទ្ធិរបស់អតិថិជនសិទ្ធិរបស់អ្នកជំងឺសិទ្ធិរបស់ប្រជាពលរដ្ឋសិទ្ធិរបស់មនុស្សវាផ្ដើមចេញពីការគោរពការផ្ដល់សេវាសុខភាពផ្ដល់ឱសថប្រកបដោយគុណភាពបើឱសថគ្មានគុណភាពកុំនិយាយអំពីរឿងសិទ្ធិមនុស្ស
ខ្ញុំសួរគេដែរប៉ុន្តែគ្រាន់ថាខ្ញុំសួរហ្នឹងពេទ្យគេខ្ញុំតែមើលថ្ងៃខែខ្ញុំសួរគេអញ្ចឹងប៉ុន្តែដូចជាខ្ញុំដឹងថាមតិគេទូទៅមិនចំពោះខ្ញុំដូចជាទុកចិត្តលើកន្លែងលក់ថ្នាំ
ដឹងដែរដឹងថ្នាំខ្លាំងៗដឹងមិនផងយើងលើថាយើងមិនស្គាល់ថ្នាំហ្មងយើងគាត់ថាគេពេទ្យគេថាឥឡូវយើងទៅទិញថ្នាំផ្ដាសាយគេឲ្យថ្នាំផ្ដាសាយមកយើងចេះតែលេបតាមក្បួនពេទ្យគេឲ្យមកទៅយើងទៅផ្សំឲ្យគេផ្សំឲ្យទៅ
ខ្ញុំលើតាមគេនិយាយតែខ្ញុំអត់ទាន់បានទិញប៉ះថ្នាំហ្នឹងឯងតែពេលច្រើនខ្ញុំមកទិញតែកន្លែងគាត់នេះឯង
លឺដល់លឺគេនិយាយដែរក៏ប៉ុន្តែអាហ្នឹងមកពីយើងទៅផ្សំកន្លែងឱសថស្ថានដែលគ្មានអីខ្លះច្បាស់លាស់អីចឹងបង
Drug-resistant strains of malaria were first identified along the Thai-Cambodian border. Of major international concern is the threat of the spread of these strains to areas with high rates of malaria, such as the African continent, which would have devastating consequences. Researchers have linked the contribution of poor quality medicines to the development of drug-resistant strains of malaria. In areas with limited financial and human resources, it is difficult to monitor and regulate the cross-border flows of people and commodities. Fake and poor quality medicines infiltrate the border markets, especially in areas with weak regulation and a lack of public awareness about the dangers of these types of products.
On peut considérer, si vous voulez, que sur les 750 000 personnes qui décèdent chaque année, selon les sources officielles du paludisme, il y a environ 150 à 200 000 morts qui pourraient être évitées si les antipaludiques en circulation contenaient le principe actif par an. Oui.
Clearly, this is a reasonable number, I mean, given the scope of the problem, but I would add that it might even be an underestimate for the following reason. You have situations where there's treatment failure as a result of taking medicines that purport to be medicines, but they are not, and as a result, patients succumb to the disease. I wonder how many of these situations are being included in the calculation of the fatality.
Mesot is a town nestled on the Moi River of the western Thailand border with Burma, home to thousands of migrant workers who cross into Thailand seeking stable employment and essential medical services. In the informal street markets, a colorful array of dubious medicines from Burma is widely available. These unregistered medicines and herbal products from across the river provide migrant workers with familiar remedies against many diseases, including malaria, one of the major concerns among this population. Organizations such as the Shoklo Malaria Research Unit provide much-needed outreach and healthcare to vulnerable people on both sides of the river. A recent case of a malaria patient who had taken fake artesunate to treat his illness inside Burma was reported by the clinic. Thinking he was being cured, the patient had unwittingly consumed an ineffective medication with tragic consequences.
Of course, it was dramatic because the patient died. We managed to get hold of the tablets of artesunate that he had used and analyzed it, and it was totally counterfeit. There was nothing in it. And to trace back the shop in the village where he had bought these tablets, and there was an interesting reaction from the village community, and the village head called for a meeting and explained to the people that it was dangerous to buy drugs like this, and they collect all the medicine they could find in the village and burnt everything.
I find it unbelievable that people do that. You know, so it's kind of to manufacture a drug that they know can potentially kill someone because someone takes it in the belief. Someone with malaria will take it in the belief that it's going to cure them. They might have come, you know, they might have travelled for a day to get to somewhere where they can get a drug, they buy the drug, they think it's going to kill them, they go back home. They don't have time to kind of go back again and get a good quality drug.
The initial data that we collected suggested that it was widely spread over the whole of mainland Southeast Asia, from western Burma through to southern Vietnam and to southern China, over especially poor communities that had no other access to antimalarials. So in 2005, with very little happening to try to stop this problem, we collaborated with WHO, with Interpol, and with a range of forensic laboratories to try and obtain evidence as to where these may have been coming from. We had our suspicions, but we had no firm evidence. So by doing that, we looked at the type of chalk in the tablets. I assumed before that chalk was chalk, but no, there are many different types of chalk. And the chalk that was found was a type that is only mined on a large scale in southern China. And we also looked for traces of plant material, of pollen within the tablets. And that again suggested that the tablets had an origin either of the raw material or were being manufactured in southern China or in an area near there. Obviously, with wind blowing pollen, it's not a very accurate tool, but it suggested that it was from that general region.
The traditional path of spread of drug resistance in the past to chloroquine and to sulfadoxine pyrimethamine in Plasmodium falciparum was to move westward, to cross over Thailand, through Myanmar into India and then into the African continent. And so the nightmare scenario of a global pandemic of artemisinin resistance with accompanying increase in morbidity and mortality is obviously what we must stop at all costs.
If you have a substandard drug, so an artesunate, and it's in a low dose and not in the full dose, then from the resistance point of view, that's fantastic for the parasite. Whereas a good quality, genuine product, hopefully it should knock out the parasite.
ហើយយើងមានការសោកស្ដាយណាស់ប្រជាពលរដ្ឋដែលគាត់កើតជំងឺដែលអាចព្យាបាលបានមកថាម៉ាឡារីជំងឺគ្រុនចាញ់ព្យាបាលអស់តែ$4-10ទេជាយ៉ាងច្រើនហេតុអីក៏កម្ដៅគាត់ស្លាប់បានយើងមានថ្នាំ availability of drug anti malaria drug ហេតុអីក៏មិន access ទៅដល់ប្រជាពលរដ្ឋបានហេតុអីក៏ប្រជាពលរដ្ឋ access ទៅនឹង fake drug ទៅនឹងឱសថខ្លាំងៗយើងសួរសញ្ញានឹងតើការស្លាប់របស់ប្រជាពលរដ្ឋរាប់រយនាក់នេះវាជាភ័ព្វព្រេងសំណាងរបស់គ្នាឬក៏ជាកំហុសជា mistake ជាកំហុសរបស់
system យើងពិចារណាឡើងហ្នឹង
It was in this hall here where our collaboration between WHO and Interpol started. In 2005, the WHO Regional Office for the Western Pacific, jointly with the Southeast Asian Regional Office, organized in here a meeting on counterfeit medicines. We had in our hands samples of these fake artesunate. And through this collaboration, a very sophisticated forensic investigation was launched with the aim to find the production site as well as distribution rings, and of course with the aim to disrupt both production and distribution.
Alors, au cours des enquêtes que nous avons pu coordonner avec Interpol dans la lutte contre cette contrefaçon, l'un des défis auxquels nous sommes confrontés, c'est de retracer l'origine des produits contrefaits. Et en Asie du Sud-Est, nous avons vu des contrefaçons de médicaments qui étaient extrêmement bien faites, donc avec un packaging